I work for I work for UW Health, which is a large academic medical center in South Central Wisconsin and now Northern Illinois. So as you can see there, that's kind of where we all are and all the hospital and regional partners that we have in the area. Currently, I am the manager for behavioral health and primary care, which means that I oversee 21 different sites that have integrated care, the collaborative care model to be specific. Those sites include 24 different adult clinics and 5 pediatric clinics, and I'm currently overseeing over 40 clinicians. So, like I mentioned already, here at UW Health, we do a collaborative care model. So for those of you who may not be familiar, I'm going to talk a little bit today about what collaborative care is. And I really like to think about it as kind of a scaffolding. So collaborative care is kind of, it's a model, it's an outline, it's a way to bring integration into your system, into your clinic. But it's really up to you kind of how you use that scaffolding and what pieces you work specifically for you and your site. I've worked really closely with the AIMS Center at the University of Washington over the years, and I think this is a really important part of collaborative care that sometimes gets overlooked. There's some really amazing research out on kind of what collaborative care is and how it works. And there's really specific papers written on specific models of collaborative care. And I think that sometimes the danger is that we read that kind of really impressive research and think, well, there's only one way to do it. And that's just not true. And I can tell you a little bit more about that when I talk about how we do things here at UW Health. So if we're thinking about whether or not a program is a collaborative care program, what we'd want to do is really think about these core 5 principles. These are what are called the principles of collaborative care. And collaborative care really focuses on these 5 things. So it needs a patient-centered team approach, meaning that I like to tell people that I'm not a salesperson. I'm not like pitching something to a patient. I'm just trying to help them find what works best for them. And so any kind of care that we're giving to a patient, it's really surrounding that patient and what's best for them. I'll get into a little more detail in a minute here for each of these roles. It also needs to be population-based, meaning that we are not just thinking about the patient in front of us, we're thinking about what's best for kind of all the patients here at the clinic that we're working at. At any time, a patient could come in and become a collaborative care patient. Depression, anxiety, mental health issues in general are things that come and go. They're episodic and often chronic. So we really want to focus on what can we do to best treat the entire population of mental health needs at that specific clinic. A really, really important piece of collaborative care is the treat to target model, which means that we're really specific about what outcomes mean. So for instance, in our model at UW Health, we specifically use the PHQ and GAD for our outcome measures, the GAD-7 and the PHQ-9. And what we're looking for is either remission or a 50% reduction in symptoms. So we're looking for patients to get significantly better before we feel like we've done enough. So a patient coming back and saying, yeah, I'm feeling better, that's not necessarily enough for us. We really want to make sure that patients are really seeing a significant decrease in symptoms, that they truly are getting kind of that positive feedback loop before we feel like our work with them is done. And it's also evidence-based. There's a lot of research on how collaborative care as a model is effective and how it works. And the interventions that we use with patients are also evidence-based. And like I said, I'll get into that a little bit more here in a minute. And then lastly, accountable care. When we're thinking about a system of care, we don't want to just be thinking again about that patient in front of us. We want to be thinking about how is treating this population really helping everyone in our community, and we want to be accountable for that. That's part of the reason we use measures like the PHQ-9 and the GAD, is that we want to be able to show, yeah, patients really are getting better. And as I'll talk in a moment, that sometimes even progresses beyond those types of measures. All right. So often in my line of work, we use kind of the ship captain or a boat, or in this case, a rowing team, to describe what patient-centered care looks like. And really, when we're thinking about what is patient-centered team care, we're thinking about kind of surrounding the patient with a team that's caring for them. But there always needs to be a team leader, right? We need the coxswain, we need someone shouting out the directions. So in collaborative care, that's always the PCP. The medical provider is always the one who's in charge of the care. They're the one leading the way, and the rest of us are there supporting them and the patient. And I will say, I really want to emphasize this point, that bringing collaborative care into a clinic is not about just adding another piece of the puzzle. It's transforming care. So the way you do integrated care, the way you take care of depression, anxiety, trauma, substance use, when you bring in a model like collaborative care, should change everything about how you've been treating those folks so far. It's not just bringing on an additional team member or two and saying, oh, these are these extra people over here. It's about everyone shifting the way that we talk about patients and the way that we care for them in the clinic. And this is where I really feel like the patient-centered part comes into play, because we're all going to try to help that patient figure out what's best for them. And this is where some motivational interviewing skills are really handy. So at your organization, if you're not familiar with motivational interviewing already, I highly recommend it. We actually did something which I thought was really amazing a few years ago. Any new provider, that means medical provider, staff member, nursing, behavioral health provider, any new provider that comes to our organization gets trained on how to do motivational interviewing, which has really been, I think, part of that transformative care that's really helped patients, because it helps meet patients where they are and help them, become more comfortable with change. I'm just going to take a quick moment to pause. I have a habit of talking kind of fast. I want to make sure I'm not losing anybody. Does anyone have any questions for me before I move on? Okay. If you do, feel free to raise your hand or enter them in the chat. Another really important part of that patient-centered team is something called stepped care, meaning, in collaborative care, we're pretty explicit about the fact that we don't want patients to languish. So often what can happen in the bustle of a busy primary care setting, which is pretty much every primary care setting now, is that patients will come in with an issue. We try to treat that issue, and then we might not always see them back right away. And so, especially if, it's harder to get an appointment, or that patient is depressed and it's hard for them to follow up, they can kind of disappear for a few months, and then we might not even know what's happening with them. Collaborative care, the goal of it is really to have eyes on that patient pretty intensely with the collaborative care team, so that doesn't happen. And when a patient needs care, we're giving it to them in that moment as quickly and as efficiently as possible. So that means we have the behavioral health care manager, or as you'll hear me talk about them, the behavioral health clinician, the BHC. We have them following patients pretty intensely, so that if someone, isn't getting better, if they are suddenly lost, we can't find them, they're not showing up for appointments, we have someone who's reaching out and trying to engage them in care and trying to make changes to their care if they are not getting better. And that's actually very important, because a lot of the research will show that patients who are engaged in their care, patients who are showing up, patients who are taking recommendations, or not even, but if they're just engaged, they're answering emails, they're showing up for appointments, they get better quicker. So often the people who are not as engaged are the ones that we really need to worry about. But those are often the ones that are silent to us unless we have eyes on them. So step care is really a way to keep in touch with those patients and make quick changes in their care if they are not feeling the effects. So here's kind of a little outline I like to show folks that just talks about, it kind of gives an example of what that step care might look like, So maybe we're seeing a patient who just got diagnosed with anxiety, and they have started meeting with a behavioral health clinician to talk about some problem solving strategies. And after a few weeks, nothing's really changed. The patient is still pretty anxious. We haven't seen a lot of movement on their GAD-7 scores. That would indicate to us, man, if in 2 months that patient's not feeling, some kind of relief, we need to change what we're doing. So that might be an opportunity for the team to talk to that patient about medication or a change in the kind of intervention that we're giving. And we will continue to do that. It's an iterative process. We'll continue to check in with patients and see how it's going and change our approach as they go through care. So having that kind of intense follow-up is really how we help patients change and get better. I really love this picture as well. It shows kind of another version of our patient-centered team care, which is really addressing tiered care. And this is from the World Health Organization. I have the resource at the end of my slides, but it's really looking at, like, how do we see patients and how are we helping them move through the levels of care as needed? So another really important role for the collaborative care team in primary care is to help see patients at that primary care level and help guide them to these higher levels as needed. Often what happens in a lot of primary care settings is, like I said, patients might disappear for a while. They may not be motivated to stay in touch. And then we don't know if they're getting worse. And so what happens is they might show up then in crisis, or they might show up when they aren't feeling very well and they've kind of reached their max. And that's when they'll suddenly need a jump in care, right? So the goal with collaborative care is that we catch that before it gets that bad, and we try to treat it so that that primary care mental health services is really being utilized well. But there are still patients who are going to end up in crisis. There are still patients who are going to come to our door and need something more than our care. And the goal of collaborative care is also to help create kind of a pipeline, a relationship with higher levels of care, so that we can help guide those patients up to those higher levels when needed. And really quickly, will the slides be available? Yes, I did send those. So yes, thanks. You might remember one of the other principles of collaborative care is population-based care. And what that really means for this kind of a model is that we are proactively screening patients. We're not always just waiting for them to come in and tell us that they're not feeling well. We are going to proactively give them screeners to check in on them and see how they're doing. So there's no prescribed way to do this in collaborative care. At UW Health, what we do is that anyone who's getting a yearly physical or a yearly exam gets screened. That is not a perfect way of doing it. There are other ways of doing it. I know other organizations maybe have a way in their EHR to flag someone yearly so that once a year, no matter what they're coming in for, they get screened. Some organizations proactively do a PHQ-2 at every single visit. It doesn't matter. You just need to have that screening piece. You just need to be proactive about it so that, again, we aren't waiting for patients to be in crisis or feeling poorly before they reach out to us. Another really key part of collaborative care population-based services is tracking patients in a registry. So here at UW Health, we call it a reporting workbench. We have the EPIC electronic health record, and we have a pretty slick version that looks at Basically, when we do a handoff with a patient, we add them to our team. We're add ourselves to their care team, and they just automatically get added to our reporting workbench where it compiles a bunch of really useful information, like what was their first PHQ score? What was their most recent PHQ score? When was their last visit? Are they on meds? Things like that. But there are many ways organizations can do this. You know, there's Excel sheets out there where you can manually enter things. There's EHRs that have different strategies for documenting this. But having that panel, having registry visible to the people on the team is really important, because that gives folks a way to do that proactive outreach like we've talked about, so that you aren't losing patients to follow up. It's also the consultation driven outreach, which means, you know, not only are we trying to outreach to people so that they don't fall through the cracks, but when we're doing our weekly consultation, which I'll talk about in a moment, then we're able to say, oh, hey, it looks like this person on the panel isn't doing so well. How can we support them better? Who's going to reach out to them? And that is another way of doing population-based care.
Dr. Well, there's a question on the chat. Are you using the Compass Rose component of Epic for the registry?
Great question. So we actually aren't. And the only reason that we aren't is because Compass Rose came about after our program had already created its own thing. So we have looked at kind of like retroactively implementing Compass Rose, and I have seen snippets of it. It looks really slick, but we are not currently using it. I will say we are using, though, like similar to Compass Rose, the episodes feature in Epic, and that has been infinitely helpful. So that way, you know, if someone comes to us and they're seeing us for an episode, we can track that, and then we close that episode when they're doing better. And then when they come in, we just open another episode, and we can kind of see those all gathered together in our EHR. Treat to target. So this is also a unique part of collaborative care, where we aren't just looking at, is a patient reporting feeling better, but we're actually looking at specific outcome measures. The most common of these are the ones that we use, the PHQ-9 and the GAD-7, but you are not by any means limited to those. I know other organizations have used like some quality of health measures as outcome measures. We also use formal goal setting with patients in our EHR, and that can help as well, because we can see that not only how many goals does a patient have, but how many have they actually reached, like how many of those goals have they set and accomplished, and how many are they still working on, or how many have they partially accomplished, things like that. So between kind of goal setting with patients and using those specific measures, we're able to see how are patients getting better, and are they improving? And if so, how much? Because another thing the research will show that lots of patients will get kind of an initial improvement in scores, and they'll say, man, I'm feeling better. And then a few months down the road, they're like, oh, I'm not feeling so great. And it's not that their scores have gotten worse necessarily. It's just that they never saw the full benefit of therapy or medication, and they weren't really to relapse prevention yet. And we kind of stopped treating them before they got better enough. So what's really helpful in treat to target is you have a registry where you can see how, like, has this patient actually improved, or did their PHQ just go down like 4 points? And maybe we need to wait until we can get them all the way down to like a PHQ of 5. So that's been really helpful too, I think, for a lot of our primary care clinics, is to see, like, making sure we can make sure that parents or that patients get full and adequate response to their treatment before we send them off. Lastly, evidence-based. So I shouldn't say lastly, there's one more slide left about the principles, but there's many research studies out there on collaborative care. Here's just a handful that I'm putting out there, but there's a lot. And it just means, collaborative care is a very well-studied model. I will say kind of the interventions that we use in collaborative care, the ones that have been very well studied are things like behavioral activation and problem solving treatment, as well as, other adjunct kinds of interventions like motivational interviewing. And, but I will say there's other things that you can use in collaborative care that may not be explicitly talked about in the research, right? Like there's plenty of interventions that we know work well, like CBT. And many of my providers use CBT-based interventions because my providers are all medical, or they're all licensed therapists. So they either have their license in social work or therapy or psychology. So they have skills that they can utilize outside of the problem solving, MI, behavioral activation realm. But those three are also very effective. All of those things are very effective when we're talking about chronic mental health problems. So I like to call it kind of like the menu of options when I'm talking to behavioral health clinicians and I'm onboarding folks, that often when we get a patient coming into our office, once we discover like, yeah, this is what's really going on with them, they have depression, or they have a panic disorder, or they have, an acute stress disorder, we can know as clinicians what's helpful for that patient. So in that moment, we can give them kind of a menu of options. We can say, here's what we know works for anxiety. I heard you talking about sleep issues. We can talk about sleep hygiene. I also heard you talking about feeling really overwhelmed. We could talk about doing some problem solving interventions and how that might help you. Which one of those sounds best for you today? And that's, again, that patient-centered piece, bringing the patient back into care and asking them what they feel like sounds best to them, what they think is going to be helpful for them. And also always including medications in that menu of options, right? Talking with their PCP about what can we help this patient with right away today if we wanted to get a medication on board. So all of these things can be interventions. I like to sometimes joke with my clinicians that we're really doing like evidence-informed treatment, because there really isn't any explicit model of care on like how to do exposure therapy with a patient in 30-minute visits across 10 visits. But there are very similar things out there, very, protocolized kinds of treatments that we can adjust for our setting. And lastly, one of the main principles is that accountable care feature. And this just means that we are making ourselves accountable as a team in an organization for whether or not patients are getting better. So that really gets back to that iterative process, that like if a patient is coming in and telling us they're still not feeling better or their scores have not decreased enough, that we are doing something to change care to help them feel better. Systemically, this looks like improved outcomes for patients across different levels. The research has shown over and over again that the biggest improvements you get with patients who are in a collaborative care model is not from their mental health per se, but actually in their medical health. So often kind of our accountable care measures are things like hypertension or A1C, because that's often where you'll see the greatest outcomes. I put a snapshot here of our organization and what systemic accountable care measures we look at. So you'll see that in each of these charts on the left in blue is where our patients were at prior to their episode in collaborative care, and then where they're at during their episode in green, and after they've completed their treatment with us, they're in red. So you can see that overall, actually the biggest benefit is in urgent care and ED utilization. And when I say that ED utilization is for non-psychiatric emergency visits. So you can see that actually there's quite a big change overall for the patients after they've received care, even years after they've received care. in their medical outcomes. So now I'm just going to take a minute to pause before I get into the weeds about team members and what that takes, just to see if anyone has any thoughts or questions about what I've talked about so far. What are people's familiarity with collaborative care? I'm curious.
Just starting to get going with it, so no experience with implementation yet.
Do you guys have Epic, Stacy?
Yes, so we're trying to figure out how to maximize it to get what we need.
Yeah, I will say the ISP is a tricky one. There's a lot of things that you can do. It's kind of choosing what's best for your organization. But I will say, if you can automate as much as possible, it'll make everyone's life a lot better. We slowly automated over time. So we were doing some manual registry work in the beginning, and then we went to reporting workbench, and then eventually we got to automatic billing even with collaborative care codes, and it's been a game changer. But it wasn't all like that at once.
Love to talk with you offline to understand how you got to that billing, automatic billing components of it.
Yeah, I would be happy. That's a whole other talk, but I'm happy to touch base offline about it. Getting into some of the team members here, I'm sure if you've ever seen anything on collaborative care, you've seen this picture. It's a pretty common pictogram of what the team really looks like in collaborative care. And again, like I said, I like to use the boat analogy. And so when we're thinking about who's driving the care and how it's working on a collaborative care team, the medical provider, the primary care doc, is really the captain. So they're steering the care. They're the one who has a lot of frequent contacts with the patient. They're prescribing. They're doing a lot of that heavy lifting. And then the behavioral health care manager, or as they're called at UW Health, the BHC, they're really navigating. They're probably meeting more with the patient in between medical visits. And they're touching, or at least they're touching base more with the patient, right? They're doing those outreach calls and meeting with the patient for interventions. So they're really helping say, this is what way we need to go with this patient. And then the psychiatric consultant is kind of like, I like to think of them as the lighthouse operator. They're kind of on the shore, but they're saying, this is how you get there, right? Like, this is what we need to do to help get you home. And so they are really helping guide the medical provider and the behavioral health consultant to help get things in the right direction. So if we're going to break down each of these roles, like I already mentioned, the medical provider is the one overseeing care. They are the one prescribing medication because the psychiatric consultant is just a consultant. They do not prescribe. They're the one diagnosing too. The medical provider is the one saying, this patient has anxiety, so I'm going to hand them off to the behavioral health care manager. Or I think this patient has this, so they would qualify for this kind of treatment. And they're the one doing that warm connection. Now, you will hear a lot of conflicting advice on warm connections. And some organizations say it's vital, you have to do it. Other organizations and research will say, you can do it in this like kind of altered way by just calling the patient afterwards, or you don't even really need it at all. And I will say, like, the data is really mixed on this because I think it really is unique to each organization. We found at our organization, we actually looked at the data on warm connections to see how much does that live connection how does that change things? And what we found is that in our organization, it that having a warm connection really helped increase the likelihood that a patient was going to be engaged in their care. So because that seems to be kind of a modifying event for whether or not someone's going to be engaged, and we know engagement is a big way that patients get better, we really push the warm connection. So we try to really make that a key feature of our model here. Now, the behavioral healthcare manager, or like I said, in our group, the BHC, they're really in charge of kind of orchestrating care and doing these kind of main 4 buckets of work. So they are meeting weekly with a psychiatric consultant, and they are rounding on patients. They're both the consultant and the BHC are looking at the registry, and they are trying to decide, like, what can we do for these patients who aren't getting better? And then they communicate that to the medical provider. They are also a care manager. And I try to be really clear about they're a care manager for their panel of patients. They're not kind of coordinating care with patients who are outside of their panel. But for those patients they're saying, they're helping, making sure, are they getting better? If not, why? Are we getting screeners on them? What do they look like? Reaching out to those patients who need that extra outreach, helping, connect patients who need a higher level of care. That is their role. They are also, for my clinicians, they're a brief therapist. There are many collaborative care models also that have nurses. And for that, I mean, you wouldn't be doing therapy, obviously, but they are absolutely doing brief interventions like problem solving and goal setting. And those kinds of interventions are very important. So a lot of my providers, like I already mentioned, are doing skills like mindfulness, interpersonal therapy, and cognitive behavioral therapy, as well as things that are pretty common, like I already mentioned, like motivational interviewing. And lastly, they are responsible for that warm connection. So the warm connection occurs when a patient is in the office. They're expressing to their medical provider they have some sort of, ailment like anxiety or depression, trauma, what have you. And the medical provider brings that BHC physically into the room and introduces the model of care. And this is really part, I think, too. I think the unique part of the warm connection is that it also really makes sure that we're doing that kind of transformative care. We're making sure that patients know we're working as a team and this is how we're doing it. You're going to see it live. Like, that's really powerful, I think, for a patient to see and experience. The psychiatric consultant, or as we call them in our model, a team psychiatrist, they're helping the behavioral health care manager look at the registry. So when they meet weekly with their BHC, they are looking at the registry with them. They're saying, oh, what's happening here? Let's talk about this patient. And they're really helping the team with any kind of diagnostic clarity, medication recs, or treatment planning. They typically don't see patients one-on-one, but they can do a live evaluation. So we don't use these very often in our version of collaborative care, but they certainly will happen if we maybe have a patient that we're like, man, I need someone else's eyes because I'm not sure, like, is this patient just really anxious and paranoid, or do they have schizophrenia? I'm not sure. And that's where it can be really nice to have a one-time meeting with the psychiatric consultant to help say, like, this seems like the right diagnosis for this patient, and that there then is going to inform care. And just like everyone else on the team psychiatrist is responsible for abiding by those same kind of like stepped care evidence-based principles. And I bring this up because it's really important that if there are patients who need care outside of us, that we're helping send them up the chain to those types of more formal outpatient settings or inpatient settings. So a psychiatric consultant can be really helpful in that effect too. They can be, they can be the person that says, I have talked to the team about this, and I really think this patient needs to be sent to the hospital or something. And then staff are so very important. to making any integrated care model work. In our model of care, we explicitly outline for every staff member what their role is in the collaborative care model. So for the nurses on our team, they need to be able to explain this model of care to patients and help triage calls from folks who might need our care. The front desk staff, they're responsible for giving folks screeners and scheduling appointments for behavioral health consultants. And our medical assistants are responsible for connecting folks. So often when an MA is rooming a patient, that's when you find out that they might be coming in for anxiety or something. So it's really important that our MAs also know how to talk about the model and relay that information to our medical providers efficiently. And then lastly, our clinical managers, our clinic managers are responsible for kind of helping navigate things on the ground. They're going to help onboard our behavioral health clinicians as well as other staff. And again, make sure that the discussion around collaborative care is like any other discussion about what we do in clinic. So just like we make sure that we have a workflow for rooming patients, we have a workflow for how to connect someone to collaborative care, and everyone knows that workflow. So I will just say, you know, when it comes to communication, I err on the side of over communication. So in my mind, there's no wrong way to communicate. So we have lots of formal meetings set up to streamline communication, but I also make it clear that informal ways are fine and acceptable too. So this is a little tricky because I honestly think it's pretty specific to each individual setting. You know, we have clinics where docs use our kind of like instant messenger system in the EHR all the time, and that's how they like to communicate. And then we have other clinics where someone will come knock on the door and just sit down in an office and talk to you. Neither of those are wrong. You know, it's what we talk about is kind of finding that Goldilocks effect, finding the right temperature for your clinic, finding how your team and that staff and that medical provider wants to talk, and trying to really foster that. So I'll show you some things in a minute, but also kind of going back to that iterative process, a good example of, you know, trying to figure out the Goldilocks effect for communication. In the beginning of collaborative care, we were carbon copying all of our providers, our medical providers, on every single visit. So they got a copy of every single note, every single phone contact, everything we did with patients. And we got very clear feedback that they did not like that. It was overwhelming. It was way too much. So then we stopped doing it, right? We said, great, okay, that way of communicating doesn't work. We won't do that. So sometimes this is also just a process that you learn from, right? You try something and you find out, oh, that was great, or no one's going to like that. And then you change things. We have a really intense meeting cadence that I just wanted to throw up here to show you guys. But I think that this also really helps with communication. And I have pretty strong feelings that the more you can invest in both formal and informal avenues for communication, the better. So my teams have a lot of time blocked off in their schedule to meet, and that's purposeful. So as a BHC team, meaning me and my supervisors and the 40 behavioral health clinicians that I supervise across the organization, we check in weekly for a half an hour. And then each individual behavioral health clinician checks in with their supervisor once a month as well. And then every team at a clinic also checks in every month. So I might have 3 BHCs in a clinic. They might not always be in clinic on the same days because we have a hybrid work from home kind of model. So some days they're working from home, some days they're in the office. So then we make sure that every month that team of BHCs is also meeting. I will just note that when I'm onboarding someone, that this meeting structure is actually much more intense, and we meet for longer, more frequently. And we kind of gradually step away from that. And by the time someone's at 6 months with us, they don't meet with us as often. In clinics have monthly staff meetings that we attend as BHCs and medical providers. And then there's monthly provider meetings where all the medical providers and the BHCs meet. There are also ad hoc check-ins, again, that differs from clinic to clinic, and some of those clinics also like to use the EHR communication. And then I have a leadership team that I meet with regularly, where it's myself and a physician lead from primary care, as well as a psychiatric physician lead for the team psychiatrist. And we meet together weekly as well. We do quarterly check-ins initially when we're going live at a clinic. So if a clinic is new to collaborative care, we check in with them every few months. And then we also do ad hoc clinical meetings. If someone's struggling with something or they need some help problem solving as a clinic, we will come show up to their provider meetings as well. Once collaborative care is established in a clinic, we just do a yearly check-in where once a year we go out to every single clinic and say, hey, this is your year in review. This is what collaborative care has looked like at your clinic, at your site for this year. What kinds of questions do you have for us? Also, here's some reminders. So we're always going back, always checking back in. I feel like this is a good time to pause again and see if there's any thoughts or questions for me.
Hi, Dr. Wells. My name's Stacy Cook. I was just curious if you had a breakdown. You said you have about 40 BHCs. How many team psychiatrists do you have? And how many BHCs are those team psychiatrists covering?
Yes, great question. So we have about 5 team psychiatrists right now, but they are not all full-time. So some of them have, like 1 day dedicated to collaborative care. Some of them have 3 days. We use a formula that's essentially an hour, 20 minutes for each BHC is, I should say, let me back that up. Each team psychiatrist needs an hour, 20 minutes per BHC per week. So that's how we kind of calculate FTE for that team psychiatrist. So 3 BHCs equals 4 hours of team psych time. Does that make sense?
It does. What would you say, and I know that this may not be something to easily answer, what would a panel or registry volume look like during that 1 hour and 20 minutes?
Oh, yeah. No, I can answer all these questions. There's easily,
great.
bring them to me. Yeah. Typically we say the goal is between 6 to 10 patients to round on in an hour. I would say like more often it's 6 to 8 that they're rounding on within that hour. So the hour and 20 for team psychiatrist is meant to be, we expect them to take about 20 minutes, like documenting and reviewing. And then that hour is, then they have that hour directly with the BHC.
Thank you. I appreciate it.
Great questions. Yes. Does anyone else have any questions?
I'm sorry, I'm going to jump in again. I should have
Yeah.
needed to formulate them all before asking. So what is the panel size or the registry size per BHC?
Yes. Yeah, so typically we recommend between 70 and 100. I will say that varies dramatically. It is rarely below 70. Like occasionally that might happen in a really small clinic, or if like a bunch of people went on vacation for a while or something. But more often than not, what we find is that we have to often like help folks who maybe have like 150 people on their registry. I will also say different organizations deal with that differently as well. If I routinely have a BHC with 150 people on their panel, that tells me I need another BHC at that clinic. And maybe not a full-time BHC, but we obviously need help because there's a high enough patient volume. But that doesn't mean like BHCs don't just come out of the woodworks. So sometimes what we do to manage that is that we help cull their panel and send patients out that need higher levels and help them, close episodes for patients who are doing better. Or we might just give the clinic a heads up that patients are going to be scheduled out a little bit farther out. I mean, the goal of collaborative care is access. Like part of the goal is to get patients in quickly. So another one of our measures is that we get patients an intake within 2 weeks. And we're usually pretty good about that. But when things are hectic, it could take up to a month. And I don't like it taking a month. So we will give clinics a heads up when that happens. Some other organizations like turn off panels and stop taking handoffs. I flatly refuse to do that because in my experience between this organization and 2 other organizations I've worked with previously doing integrated care, that almost always stymies handoffs. So even when you turn the faucet back on and say, we can take handoffs again, people are often hesitant to do so because they don't know when you'll get busy again. And it kind of breaks down trust in my experience. So we never stop taking handoffs. We will kind of just let people know things are busier and it'll take longer for patients to get in, but we never stop taking them.
Hi there. I just had a question. When it regards to registry that you mentioned, is that referred or those that are enrolled?
Great question. So those are the same for us because when we do a handoff, we automatically enroll that patient because that is considered to us the beginning of the episode of care. So if a patient doesn't show up for their intake or doesn't call us back, we will continue to reach out to them because that's again part of, I think, that engagement in care, that from the handoff, we consider that person our patient. That means that there's a handful of, like, there's a significant minority of patients who never really engage in care with us, and eventually we close them out. But they are on our panel from the minute we do the handoff.
And then how often would you say you meet with the patient? Like every week, every other?
Yeah, I would say that the PCP is often meeting with the patient like every month or every 6 weeks, especially if they started a medication. And the BHCs are typically meeting with the patient at those visits. Like we try to piggyback visits to help patients out, but then also usually in between a couple of times. So in the beginning, we might be seeing patients every 1 to 2 weeks. And then as they start to see improvement, we start spacing that out.
Thank you.
These are great questions.
I had a quick question. I'm just trying to understand, are you only warm handing off then people who score high in the PHQ-9 or the GAD-7? That's what
Good
I'm
question.
hearing.
Yeah. So we formally recommend doing a handoff at a 10. We are cut off for recommending a handoff as a 10 on both the GAD and the PHQ. So that's like moderate symptoms. But you'll notice I'm strategically using the word recommend because, maybe that patient might be scoring a 14, but they might have like a therapist in the community already. Or the other thing we've had happen is maybe that patient's only scoring a 6, but they're breaking down in the room and they seem like they really need some help. We're not going to say we won't see that patient because they scored a 6. So we kind of have a guideline that recommends 10 as a cutoff for a handoff when we're screening. But we encourage folks to use their clinical guidance around that, like their clinical intuition. I mean, we've had lots of patients who they initially score with their PCPs in the office pretty low. And then after an intake with the BHC, suddenly score really high. And that's often just because people are minimizing. Yeah, I think that's a really good question because I think that really speaks to kind of like the flexibility of the model it's you should screen, but it doesn't tell you any of those things, right? Like, how do you screen? So it's good in the sense that it's flexible for what works for you and your organization, but that also means you have to figure out what's best for your organization, which sometimes can take a little work.
A little follow-up question to that. So when I think of collaborative care, I'm thinking of them helping with also health needs as well. So if someone has a diabetic with an A1C that's 10 that hasn't brought it down and maybe scores fine in the PHQ-2 and 9 as well as the GAD-7, we would do a warm handoff. Do you do that within your agency, or no, it's always based on the scoring of the PHQ-9 and the GAD-7?
Yeah, so in our organization, we're really focusing on moving the mental health measures and having that inform our care. But you're absolutely right. You don't have to do that. By all means, you can have people helping goal set and do behavioral activation around things like, behavior measures to improve A1Cs, diabetes, chronic pain, many different things. Really just need like some way to treat to target. So that could be treat to target their A1C by all means. All right. So I just want to put a plug out here. I'm not going to talk too long about this slide, but just as with patients, engagement is really key when we're talking about stakeholders. So I just wanted to give a shout out to the behind the scenes team members that I work really closely with, because I feel like they're equally important. And those are folks like my revenue partners, administrators, clinic and service line leaders, coding, compliance, all of those things, community partnerships that we have. We really, I think, benefit from being a large organization, and the fact that when I have people who need a higher level of care, we work very closely with our psychiatric department here at UW Health. If you do not have that, you will need to kind of create some community partnerships for those patients who need a higher level of care. And I think sometimes that gets overlooked because that's not a direct part of the model, but it's a really important part. So I would be, I wouldn't want to forget about mentioning it. Hiring is the most important part. I cannot stress this enough. Finding the right kind of person to do this work is very important. And I'm going to talk specifically about BHCs and team psychiatrists, because that's kind of the kind of hiring that I do. And I will say I think there's a lot of thoughts on this. There are some organizations that really want to seek out and aggressively find folks who have this kind of experience, who have worked in integrated care before. And then there's other folks who are we're going to train our own, and they might have a training pipeline and also a really intense onboarding. I am the latter, and I feel very strongly about this because there are not enough of us. There never will be. And I can tell you that because as our organization has grown and hired many more BHCs to be embedded in primary care, we have also hired more therapists and psychologists and psychiatrists to work in a psychiatry program. And it does not matter how many people we hire. As we hire more, there's a higher need. And we slowly make the gap smaller between need and what we have, but we never close it. And I just think that speaks to kind of the mental health emergency that we're in right now as a culture. And I don't ever expect there to be enough psychiatrists or enough mental health providers. And so because of that, if my organization started doing this work several years ago, but we really got up and running around 2019. And I've had my team of adult and almost all of my pediatric providers for a year now. So I hired almost 40 people in 3 years, and I would not have been able to do that if I waited for folks who had experience. The only way I was able to grow my team as quickly as I was to just say, if you're the kind of person I think can work in this kind of setting, I will train you how to do this work. So that's what we do here. It takes a lot of effort and it takes a lot of time, but I think it's worth it. The kind of person I think it really takes to do this kind of work is in this slide. So it's someone who is a very flexible person who is not ingrained in kind of like the very traditional ways that we are trained as psychiatrists and therapists. They're willing to think outside the box and they're very relational. The best piece of advice I've gotten in my career is that the kind of work you do in integrated care is relational. And by that, I don't mean with patients. It's relational in the sense that it's reliant on the relationships you are building in the community that you are working in. So in your clinic, when I first came to my clinic, I've been at my organization for 10 years. And when I started, I was the lone BHC. I didn't have a boss. There were no other BHCs. I was just doing my own thing in my clinic. A lot of what I did in the beginning to make it successful was I talked to our front desk staff. I asked them how they were doing things. I shadowed every single provider in our clinic. I sat in the nurses station and I just listened to them take calls and would help walk them through things if they were unsure. That is the kind of work that makes this successful, is having someone who's willing to go that extra mile and really build professional relationships with the people they work with. And that is not natural to everyone. So if you have someone who's really interested in building relationships and working in a medical setting and likes fast-paced work, they're going to thrive, whether or not they have a background in this kind of work. That's been my experience. I do want to take a moment to go through some of the hiring competencies and then leave some time to continue talking. So for anyone who isn't familiar, there's two amazing resources out there if you're thinking about what does it take for someone to learn how to do this work. And these are the two that I've always used. So SAMHSA has a great one that's more focused on kind of systemic competencies. So they talk not only about what it takes to be a successful provider in this kind of work, but what a system needs to embrace this kind of transformative care. So they will call out things like informatics, which I actually think is really important. So I appreciate the SAMHSA version, and there's a link at the bottom of my slides to get that if you don't already have it. And then the AIM Center has their own competencies that are really great too. It's much more focused on kind of like provider level stuff, but you can see here there's a lot of overlap, right? Like both of them talk about collaboration, working as a team. They both talk about QI and oversight. You know, they both talk about care coordination, because a lot of this is just general things that once you've done this work, you'll recognize as important kind of bona fide pieces. I just want to make a call out right here for the oversight and QI, because practice-based learning and quality improvement, as well as program oversight and quality improvement from the AIM Center, these often I feel like are kind of the last thing that people think about, and they should really be the first. There is no way my program would continue to work if we did not have pretty intense oversight and that iterative QI process. I can tell you a story about a wonderful clinician of mine that was stolen from another organization in town. She works for them now, and they had integrated care. And when she went there, the first thing she told me when we touched base after a while was, wow, I can't believe how much work behind the scenes was important to making this work. And she told me how at her current organization, they really are just co-located. She sits in an office. People send her referrals through the computer. She, schedules them and they see her for care. No one is checking in on like, how are those patients doing? Are they getting better? How many visits have we had with that patient? And do they need a higher level of care? Do we need to do something different? How are we referring patients? And is that process working? And because of that, it just ends up having the exact same problems that we already have in outpatient mental health, which is that patients pile up, there isn't enough providers to go around, people are not leaving the system quickly enough or improving quickly enough, and it just gets clogged. And without that kind of QI and oversight, that happens everywhere. It ends up being a co-located process that gets too busy and cannot take on new patients, in my experience. Here's a picture of how some of these competencies look and how you can, it's a, like you can see here, it's really slick, some of the evaluations that they have online. The one on the right side is the AIM Center one that's free online. If you go to their website, it's really awesome. The one on the left is the one that we created for here at UW. It's extremely similar, but we made it specific to each role. So we have evaluations for the BHCs. We have one for team psych. We have one for nurses. We have one for front desk staff. We have one for medical providers. So everyone has an evaluation specific to their role. So they know exactly too, like what is expected from me in collaborative care. And I just want to finish up here with kind of talking about what I have found to be really important ways to gain success in a collaborative care program. Like I mentioned already, having that strong leadership team is really important. So that means having a leadership team that has invested members at different levels. If I went out to all the clinics and I just tried to like tell them what to do, I would get nowhere. Because I am seen as a leader of therapists since I am also a therapist. It makes a huge difference to have a medical provider side by side with me who I work really closely with saying, this is what we need to do, and this is how we do it. It makes a big difference to have a clinic's manager stand side by side with me and say, this is how we need to do things. These are the workflows we need to follow. Having everyone kind of represented in their role in leadership really does, I think, make a difference. It also obviously makes a really big difference to have organizational support. And I think this has to honestly come like from an administrative level. Without really strong strategic kind of goals that prioritize things like integrated care, it's easy for it to get lost because it is a lot of work. It's, as you've seen, it takes it takes feedback to make it consecutive, like to make it continue to be successful. And that means ongoing investment in this kind of a program. Buy-in has to be from the top down, because if you are not able to kind of support it from a higher level, there really isn't a way to make it successful on the ground. And lastly, we really need to just think about it as, like I said, just a totally different way of doing care. When we first started doing this in the first clinics that we rolled out to, we sat down with every one of those clinics and did a training where like we asked them to play a role. We were like, okay, when the patient comes in, how are you going to explain collaborative care to them? Tell me. And we made it interactive. We made them think about what their role was besides, outside of us just telling them. We made them say, okay, if this is a patient that needs this care, what should we do with them? How are you going to help them? And then what is this person's role going to be? And what is this person's role going to be? Because again, if it's just looked at as like a person coming in and sitting in the same space and seeing patients, not only does it get clogged up, but honestly, we're really a disservice to patients. Like that kind of care isn't as impactful as the kind of really intense team-based care that we're talking about with collaborative care. So that's my spiel. Here's my references and resources for all of you, and I'm ready and willing to take any questions.
Thank you, Dr. Wells, for such an informative session. Everybody, please feel free to unmute yourself or type in your question in the chat, whichever is easier for you to ask questions to Dr. Wells.
Dr. Wells, I'm curious on your intake. Are you following more of a biopsychosocial model, the contextual interview from PCBH, or kind of a hybrid of the two?
Great question. Yeah, I would say it's probably more of a hybrid, but actually leaning more heavily in the biopsychosocial kind of avenue. I will say that has been another part of our iterative process, right? Like there's an intake that happens in collaborative care, but like no one tells you what that intake is or what it should be. They give you suggestions, but we initially did this with buy-in from all of our stakeholders, and what we found is that the initial intake was like too exhaustive, if that's possible. It wasn't very efficient. And so we went back and we changed it with some feedback from both providers and patients around like what seemed to be the more adequate pieces of care. And I will say, when you're doing something like team-based care, there are pieces of a traditional intake you just don't need because you have the provider right there, you have the EHR in front of you. You know, like I don't need to ask a ton about family history if it's already in the chart. So what we really try to encourage is a more thorough chart review before our folks do an intake.
Thank you.
Any other questions?
I know that this might vary, but approximately how many appointments from, initial to discharge?
Yeah. So we look at kind of length of care, and since we use collaborative care billing, so we are billing not just number of visits, but also you bill on outreach, on psychiatric consultation, on things like that. So because the billing isn't geared towards a visit, it's more geared towards touches and interactions. We look at it like a time frame rather than a number of visits. So when we from handoff to a patient leaving our care, on average, it takes around 4 to 6 months for them to improve and leave our care. So pretty brief.
Thank you.
All right, I don't think there are more questions. If there are, if you think of any, feel free to follow up with us. Shoot us an email with your question. I'm happy to forward that to Dr. Wells as well. But if there aren't any questions, then thank you all so much for joining. Dr. Wells, thank you so much for your time today and for providing such an informative session. I definitely learned a lot, and I'm sure the audience have too. And we can't wait to have you back again. I know you're doing another session with us, so I'm excited to have you back again. But until then, everybody, thank you for joining. And we hope to see you all next month for our echo session.
Thank you.